difference enough there.
What's the liquid age is that 5 to the second job?
A lot of different things. That's why you see multifaceted symptoms. There's different ways to interact with the immune system that causes all the different symptoms, which is way beyond the scope of this course. So stop. Have we got any immunology? I wouldn't think he probably even does.
Yes, I know, yeah.
I don't know if we will, but that's,
They look at it.
yeah, like how they interact with every,
We haven't talked about like
I don't think I've ever.
Yeah.
You don't even know about that. And truth be told, there's some of the mechanisms we don't understand either, so it's not like you could about that because we don't know what to do. Yeah. Not gonna be real helpful to you there.
She's not here.
Yeah. Yeah. Alright, let's talk about fun things now, not a bunch of background stuff. So I don't get myself to sleep before here. So we're going to talk a lot today about Staph aureus and group-based strep. So streptococci are organized into groups. Most of them are organized into groups. Does anyone remember talking about how those are organized into groups? Sometimes we don't talk about that. How they organize into groups? Yeah. So, fine. Let me reroll this. Let's see what you're saying, but that's not what I'm asking necessarily. What antigens are used to differentiate these into groups? Sorry, I worded that question. No. They got specific names named after the woman who discovered them. Sometimes we don't talk about that. So they're called Lansfield antigens. They're named after Rebecca Lansfield. So Rebecca Lansfield was the one who discovered those antigens. Those are those antigens used in surface streptococci to differentiate them into groups. Group A, Group B, Group D. Those are the ones you use. Why I said that most of them are organized into groups is because there's some that don't make those antigens. So there's some streptococci that don't make Lansfield antigens. Streptococcus pneumoniae is an example of one of those. They just don't have those on the surface. But a lot of these you can organize into groups. The predominant, we will talk about the predominant species of these groups because those are usually the ones that cause infections in humans. But there are other species within these groups. For group A strep, 90% of the time, if you're talking about group A strep, you're talking about strep pathogens. And then we'll talk about Staph aureus a little bit here too. So what I want to make sure to make you aware of is that oftentimes, even though the different types of infections are being caused by different microorganisms, the symptoms might look identical. Do things like clinical microdynamics to figure out what it is that's causing infections. There are some differences. So even when you go back to these two, some of the differences you see here. Infections with Staphylococcus aureus, you tend to see pus being generated. So they are pyogenic. So you used to have like virulent discharge, it's pussy discharge. Streptococcus, you tend not to see pus being made. So just kind of visualize some of the differences. You have clinical microlab, some of the differences. Staphylococcus aureus is catalase positive. Group-based strep is catalase negative. So some of the ways you can sort of tell the difference between these. And just because they're caused by different things doesn't mean the symptoms are going to be different. So let's walk through some of these examples. Turn the lights off so you can see that some of them are washed out. So you have a 7-year-old, comes into the pediatrician, has these, wait there, you can actually see it now. Golden colored, kind of crusty sores on their face. The pediatrician is complaining a lot about how bad they itch and wants to continue kind of scratching. When you scratch these, it actually spreads the infection. How have y'all seen this before? Really? That's it? What is this? Little kids get it, it's super itchy, you gotta keep from scratching or it spreads everywhere.
Is it hand, foot, and mouth?
Impetigo. So little kids get this stuff, and there's a couple kinds of impetigo. This is called non-bolus impetigo. Non-bolus impetigo, it has kind of this yellow, crusty look to it. So it's initially vesicular, the crust is what vesicular means. So vesicular, I'll walk through some of these terms with you as we go. So vesicular means that it's less than 1 centimeter large, and it's fluid filled. So that's the best. And at the end of one of these lectures, I actually have a list of like what all the different types of skin conditions look like, and like which ones are bigger than a centimeter, which ones are fluid filled, and which ones. So I put it on campus somewhere. I don't remember where, but it's up there somewhere. And we'll talk about that a little bit as we go through too. So don't be too concerned about that. So that's what vesicular means. Less than a centimeter, has some fluid inside of it. It becomes later crusted, so it kind of scabs over. Superficial infection of the skin only involves the epidermis, doesn't go into the underlying dermis or subcutaneous tissue at all. It's very benign. Most cases of this occur in children. 80% of the cases were caused by group A strep prior to the past 15 to 20 years. Now, the majority of it seems to be caused by Staph aureus. So this is some of the things that have changed over the years too, the epidemiology of what's causing these infections and the presentation of these infections. So when we talk about presentation, we're talking about what the symptoms are like when a patient comes in. So the presentation for some of these has changed too. We'll talk a little bit about that here towards the end of this lecture. We'll talk about erysipelas, which is another skin disease. But again, 25 years ago, somebody came in like a little kid with this. I had this when I was a kid, I think. So 35 years ago, somebody came in with this. It's caused by group A strep. It looks exactly the same as the condition caused by Staph aureus, but it's a completely different microorganism. Why the epidemiology has changed over the past 30 years, I do not know. No one really knows that. It's just what's happened. You just don't see it caused by group A strep as much anymore. It's usually caused by Staph. So what do you think the issue with that is? What do we worry about with Staphylococcus aureus? With MRSA? You might be resistant to things, right? Staph aureus has a lot bigger problems with resistance than strep does. So you have things like MRSA. So we don't really see this, but now that the majority of the cases are caused by Staph aureus, there's a potential that some of those cases could start to be caused by MRSA. And that is a different ballgame. We haven't really seen that, but it's potential now. So just something to kind of keep in mind. So for those of you that are going to do some kind of professional school after this, whatever it may be, you might see MRSA in the Dago. I hope you don't, but I would not exclude that as possibility. Annual incidence of this, 1 to 2% annually, you see this. Annual summer epidemics. You see this a lot when kids are like out playing around and they're really sweaty and they end up getting a There's not a ton to do for it. We'll talk about that in a little bit. It usually kind of goes away on its own. Not a big deal. In fact, they usually send this, like, if a patient came in with impetigo and the pediatrician tries to culture a little bit of that in the vesicle, you send to a lab. The people in the lab are literally going to wet themselves laughing at you. You just don't test for it because it's obvious. It's like it's probably staph and you just whatever. However, like I said, by the time you get to be in practice, that could potentially change. Okay. So the difference between non-bolus and bolus and IGO. So two different kinds. Non-bolus is the one we've been talking about. Papules, so papule is less than 1 centimeter, and it's not fluid filled. Those papules progress into vesicles. The vesicles are still less than 1 centimeter, but they are fluid filled. And surrounded by erythema. Erythema is a fancy medical term for that. Medical terminology, actually. Okay, good. So, what's erythema? You remember what erythema is? So, I want you to know what happened. So, erythema just means red in the skin. So, it's red around the vesicle. That's all that means. Vesicles progress to pustules. So, a pustule, again, is still less than 1 centimeter, just like papules and vesicles. But at this point, as the name kind of implies, it's filled with pus. So the fluid goes from kind of clearish and yellowish to pus. Now it's thicker and it's pus. If you take, since we're going through this anyways, if you would take a sample of a pustule, you would see a lot of PMNs. Polymorphonuclear leukocytes is another word for neutrophil. Because neutrophils, remember, are the first white blood cells that come to the site of infection. So you see a lot of neutrophil infiltration in pus. Infiltration. You see a lot of neutrophils in pus. Those enlarge and break. Thick adherent crust form with golden appearance. Whole process takes about a week. Usually you see the lesions on the face and extremities, like the arms. And then the other kind of impetigo is bullous. So that's when these less than 1 centimeter fluid-filled vesicles enlarge. They form these bullae, which are bigger than 1 centimeter. So bullae are fluid-filled, but on like vesicles, they're bigger than 1 centimeter now. And they have this clear yellow fluid that later becomes darker. So what does that mean? It means if you look at pictures of bullous versus non-bullous impetigo, non-bullous looks kind of yellow and gold. Bullous looks brown. It's just a different color. And the lesions are larger for bullous. These ruptured bullae that are bigger than 1 centimeter leave this thin brown crust. Again, there's a different color there. People with bullous impetigo do not tend to have as many lesions as like a child would with non-bullous impetigo. So there's a lot less lesions for the bullous kind. You find the bullous kind on the trunk of the body and on the extremities. And if you see that presentation of impetigo, it's usually in someone that has a very, very, very hampered immune response. In the case I gave you, an example I gave you on the PowerPoint slide there, somebody with HIV, if not AIDS, where their CD4 count is incredibly low. We will talk about those kinds of things a lot as we go through, because there's a lot of these things you typically, large type of infections you don't see in adults. You tend to see them with pediatric patients because their immune system isn't fully developed yet. If you start to see some of these types of infections in adults, something is going terribly wrong with their immune response. Oftentimes that's age, but it doesn't have to be. It could be other things too. Yeah.
So, bullae basically like pustules that are larger than severe.
Vesicles that are larger than 1 centimeter. So if you're talking about pustules, it's going to pus. Vesicles more clear, maybe yellowish, but it's, the fluidity is a lot greater.
The bullous would have to be fluid filled, whereas non-bullous.
It's fluid filled, but since you're talking about bullae, they're larger.
Okay.
Yeah, they're just bigger. There's not as many of them. Okay, so let's go back to this thing. I think I've already told you this about 4 times. So, oops. But let's go back to this. So which one does this little kid have? Yeah, the non-bullous, because it's obviously like very gold, very yellow. Okay. What about, this is why I turned the lights out. What about up here? So which ones are, well, let's just start. Let's do one. A, what do you think A is? Non-bullous or bullous? Non, right? Because you see this, you see the yellow kind of crusty stuff. You don't see that in bullous. What about this one? What about B?
Bullous.
Yeah, that's bullous. It's darker. There's not, that's a lot of lesions actually for bullous impetigo, but it is bullous. And you see it's darker. Really kind of honey color. What about C? Yeah, C is, this one's more common. Not as many lesions. They tend to be kind of clustered together, and they are not yellow at all. And these last two, D and E. Yeah, non-bullous, so really yellow. You can see you can kind of tell picture heat is, a juvenile, so, yeah, non-bullets, but, yeah.
The quantity of deletions does not say whether it's bullets or not bullets. What does that mean?
You can't necessarily use that to define the disease process. Bullets tends to have a lot less lesions than non-bullets. Is that the only thing you can use to differentiate them? No. Usually what you're gonna use to differentiate the two is, well, a few things. The number of lesions to the extent. If it's, the main one is if it's yellow or it's brown. The other one is too, if it's a pediatric patient or if it's an adult. Not to say a pediatric patient couldn't get this type of bullets and impetigo. If each patient were to get bullets and impetigo, what would you be concerned about? They have some, maybe autoimmune disease, something impacting their immune response, maybe leukemia. So if you're seeing a bullets kind of impetigo infection in a juvenile, that's not good. That's very bad. I've never seen that actually. So, but it does happen. But yeah, it's associated with leukemia as well, unfortunately. Which isn't necessarily as bad of a diagnosis in a pediatric patient. These patients tend to do really good with leukemias, have a greater chance of going into remission than adult patients do. Kids are a lot more, so we're going to use, robust than we are sometimes with that stuff. So it's not necessarily the worst of news, but it's cancer, so it's obviously not the greatest of news either. Okay. Diagnosis, you send us to clinical micro lab, at least at this point in time, they're going to die. Could conduct a gram stain, compulsion to pus. It's going to be IV, staph aureus, or beta hemolytic strep. It's not really required though, because as you all have seen, just by going through the pictures and kind of the different, like the demographic of people you're looking at, what underlying conditions they have, you get a pretty much idea without even doing any kind of sample and send it to the clinical lab. So you don't really need to do it. Does anybody remember the different kinds of hemolysis? What's the difference between alpha, beta, and gamma? What's alpha hemolysis? Alpha is partial. So alpha hemolysis is going to be partial hemolysis. So if you look at this colony on a red blood cell audit plate, remember red blood cell audit, at least what we use here in the United States, has 5% sheep red blood cells in it. In the base of the medium, you do not need to know this, but the base is tryptic soy rod, or tryptic soy alder, I should say. And what you see around that colony is it's not clear where if you held up the light, you can see through it all the way. It's kind of cloudy because it's incomplete lysis of those red blood cells. The other thing, I know you talked about this, for alpha hemolysis, what color do you often see associated with that? Yeah, it has kind of like a green coloration to it. That's because another reason it's considered incomplete hemolysis is because underlying organisms that can undergo beta hemolysis and break down hemoglobin all the way down to heme and iron. The organisms that undergo alpha hemolysis can't break that hemoglobin all the way down, and one of their breakdown products, incomplete breakdown products of that hemoglobin, has a green coloration to it. So that's why you see that sometimes. Beta hemolysis is going to be complete hemolysis. You hold out the light, you're going to see all the way through the plate because it's obliterated all the red blood cells and break down hemoglobin all the way. And then remember, gamma hemolysis is a misnomer. That just means those white red blood cells. Why we just don't call that non-hemolytic, I do not know. But we call that gamma hemolysis, even though it's not hemolysis at all. But yeah, those organisms can't do anything. And we'll talk about some different organisms and different hemolysis patterns as we go through all these organisms here over the rest of the semester. The treatment for this, as you see at the top code comparison, you do not need to know the treatments as we go through these. I put these up kind of just so you're aware of those. You don't need to know the treatments unless I specifically and explicitly tell you, you need to know the treatment for this one. You don't need to know the treatment for the vast majority of these. Reason being, it's not a foreign class, it's not a pharmacological class. And I am also not a pharmacist. So for a lot of these things we're going to talk about, the prescribing practices change over time. I I do not keep up with this prescribing practices because I'm not a pharmacist. So testing you on that, I've always felt was extremely unfair. So we're not gonna do that. All right. Okay, now you got another patient. 21, what matter? Let's say 21 minutes. 21-year-old man presents with bumps on his face. Does anybody know what this is called? Folliculitis. Good. So folliculitis, when you're around hair follicles, you usually see this on, say, somebody that obviously has hair where they shave or something like that, and then you get these kind of bumps on the face. Located around, or actually within the hair follicles, 2 to 5 millimeter lesions, erythematous, which means again it's red, often with a central pustule. Talk about what a pustule was, so that's kind of pus inside of it, that's a centimeter around. Fine surrounding color of desquamation. Desquamation is another term we have to come to you. So desquamation means the skin is peeling around that pustule. That's all desquamation. What causes it? Usually staphylococcus. There's some specific examples of folliculitis that have their own names, essentially, based on what causes them or where you find them. One of them is called a sty, which you can see. If I can hold the laser study and get it to stay on, right there. That is a sty. So glands in the eyelash follicle or around the eyelid, you have a folliculitis there, which is infection of that hair follicle. There is a specific kind of folliculitis if you decided to go in a hot tub that did not have enough chlorine in it, called hot tub folliculitis. That's caused by Pseudomonas aeruginosa. We'll talk about that here in a little bit as well. So it's caused by Pseudomonas aeruginosa. You just got in a hot tub. It's hot tub folliculitis. It's not caused by Staph aureus. But the presentations, there's similarities with presentations. Yeah.
So I know that like salt water hot tubs are becoming popular. Would that like also?
Yeah, there's Pseudomonas can handle the salt concentration. Yeah. Yeah, that would definitely help with that. Sometimes you have somebody will get in a hot tub and then there's fungi that doesn't have water too. I don't like to tell people only just to kind of look at this because you can have a lot of Pseudomonas aeruginosa in there and not actually it look like this. But if it has a greenish coloration to it, Pseudomonas aeruginosa makes different sterophores and pigments that are green. Don't go into that. Sometimes it stinks. But if you're seeing where the water looks green, it stinks, you're probably not going to get into it anyways. And there's a ton of Pseudomonas aeruginosa in there. Don't go in that. That's gross. Does it really do anything to you? No, not really. You just get a bunch of folliculitis and it itches like crazy and it usually goes away on its own. It's not that it's kind of like, oh yeah. But why would you do that? That's gross. But we'll talk about hot tub folliculitis here in a little bit. Diagnosis based on the patient history and physical exam. This is another one. If you send this to like a clinical micro lab, you try to take a sample, you send it to them, they're gonna be like, what are you doing? Like, they're gonna laugh. And yes, you do have people that send these kind of samples sometimes. Usually it's like a resin that's really green that they're straight out of school or something. It does happen. Not very often, but it does happen. Granted, if you were going to try to figure out what this was, which you couldn't figure it out, you do a gram stain on it, which we're doing a gram stain today, of Staph aureus actually. And culture the pustule contents, and that's what you're looking with gram stain on, is the contents of that pustule. Again, you look at the treatments. Usually, when you treat these, they resolve spontaneously, but if you do have to give them something, it's usually a topical, like Bupirosin again, or a topical clindamycin, but you give them. Where the folliculitis can potentially become a problem, and where you would want to culture, figure out what was going on, if that folliculitis actually progresses and turns into a furuncle. So that is also referred to as a boil. It is a deep inflammatory nodule, so it's bigger than a centimeter now, and it's extending way down into the subcutaneous tissue. So the folliculitis actually didn't resolve on its own, and it turned into a boil. where that initial folliculitis was and where that oil is, and progress into a carbuncle. So again, a carbuncle is going to fall along the follicles, and that's going to extend deep into the subcutaneous fat. Almost always this is going to be caused by Staph aureus. The reason you would want to culture these a lot of times is there are a lot of cases of this Staph aureus being MRSA. So it is a little difficult to treat. And if it keeps progressing, it can cause a really nasty infection that spreads out of that initial kind of focal, or not focal, site that could progress in, by being a focal infection. So spread through the tissue to another neighboring site. Or potentially, if it gets really, really bad, and the focal infection can turn into a systemic infection in the bloodstream, the back has to really, really, really get bad. Those people are going to take it for that point and go seek treatment. The picture I will show you there is of a gentleman. You see this on the back of their neck. You see this a lot with people that wear shirts with collars on them. So, like mine, especially dress shirts. And what happens? One of my physician friends gets this all the time. So he's like an internal medicine doctor, so he always wears like a tie. So like a shirt will just kind of rub back and forth like that. Eventually that causes irritation to those follicles. And those follicles can get normal flora from your skin, which includes things like Staph aureus. They get in that follicle, folliculitis forms. Probably don't notice that. And that folliculitis turns into oil, and you got a big oil on your neck. Think about where that's located. That's not too far removed from your central nervous system. So as a folliculitis, potentially even as a oil, whatever, probably fine. But if that progresses into a focal infection, that's not good. That's not a great spot to have. There's different ways we've treated these over the years. What the standard kind of procedure used to be is you would incise these, and then you would drain them, and then you would take, what do you call it? You would take this impregnated, like, kind of gauze stuff that had antimicrobials in it, and you would stuff it into the oil where all that fluid pus was, and then you would let it sit for a while they were on oral antibiotics, and then when you come back later on, it was called packing, so you pack the wound. Then you come back later on, and they would pull that packing out, which is as pleasant as it sounds. That is not a fun procedure. And then you would leave it alone then, pretty much. We tend to not do the packing as much as what we used to, because oftentimes that leads to more problems than benefit. What we do now is usually just incise them and let them drain, treat with antibiotics, and leave it alone. Sometimes the packing led to infection risk in and of itself, but again, differences in how long we've kind of figured out how to diagnose and treat these things over the years, because there has been some changes over the past couple of decades. Furuncles and carbuncles, where you usually find them, again, on the back of the neck, on the face potentially, armpits, buttocks. Usually people, or not people, usually places on people that are sweating. You tend to find these associated. Clinical manifestation, it hurts, it's fluctuant, erythematous, and it's obviously a nodule. Fluctuant is another one we have not talked about yet. What that means, like if you push on it, you can like feel the fluid inside of it. There's like a wave-like motion to it. It has fluid inside. Erythematous nodules we talked about, so you know those people. Labs, if it is drainable, and oftentimes if it's that large, it's going to be, you want to culture some of that drainage, some of that pus, to see what the susceptibility is. What you're essentially doing when you develop Staph aureus, you're trying to figure out if it's MRSA or MSSA. Methicillin-resistant Staph aureus or methicillin-sensitive Staph aureus. You're trying to look at the resistant factor. Treatment, again, you don't need to know. We can't talk about that anyway. Is the oral analogs you give usually clindamycin, cephalosporins, Bactrim. Depending on what the cause of it is, if it's methicillin resistant, essentially, is responsible. Okay, so again, talking about the same type of organisms here, but a little bit different presentation. So now you have a 9-month-old who presents with irritability, malaise, their teeth run down, fatigue, fever, lethargy, what would you actually say? And a generalized painful rash. So it looks almost like they were scalded, like they were exposed to like hot boiling water, and it looks like a burn. Does anyone, this one, yeah, anybody ever seen this before? I think I might have mentioned this in my room, literally like on line. So this is called scalded skin syndrome, so SSS. You don't see this in babies, you don't see it very often. But what happens is these microorganisms make a toxin that's called an exfoliated toxin, which does what it kind of sounds like. It exfoliates that epidermis off of that underlying tissue. Staphylococcus skin syndrome associated with both sensitive and resistant penicillin or Staph aureus. These species, or these strains, as I say, of Staphylococcus aureus, make an exfoliated exotoxin. Usually see it in children. It has a 3% mortality rate. Something I want to make note of too, we talk about mortality rates for some of these different infections. It's usually, if these pediatric patients pass away from this type of infection, it's usually not from this infection. That's not going to make any sense the way I word that. It's usually not the Staphylococcus aureus that causes them to pass away. What happens is they don't have epidermis anymore. It's all exfoliating off, right? Usually they get a secondary infection, and that's what causes them to pass away. You diagnose this based on clinical presentation. If the small event hasn't been burned, this is one of the only other few options of what's going on. You could potentially do a skin biopsy. We tend to not do this because the infant is already in enough discomfort. Doing a skin biopsy is not going to help them. So we try not to do that unless we have to. If you try to actually isolate Staph aureus from where you're seeing the skin peeling off, you tend to not get it isolated. It usually comes from, you can usually isolate it from the primary site of infection. It's very nice. It's usually where it starts at, where the infection starts at. Conjunctiva, umbilicus, so around the umbilical cord, where that is usually where you find the Staph aureus, not really from the peeling skin. The other thing you can do to check to see if this is scalded skin syndrome, which also is not comfortable, but not as uncomfortable as a skin biopsy, is you can look for something called the Nikolsky sign. So that one's pretty easy to do. Essentially what you do is you go up to the leading edge of where the skin is peeling off, you take your thumb, and you push down on it, you kind of push it forward, and as you push your thumb forward, if the skin rolls up in front of your thumb, that's a positive Nikolsky sign. If the epidermis is still attached to the underlying dermis tightly enough, and you push with your thumb like that, moving it forward, and the skin doesn't bubble up, you know that's a negative Nikolsky sign. So if you have somebody that comes in with symptoms like this, one of the ways to diagnose it is that Nikolsky test. Labs, cultures of blood, urine, nasopharynx, and umbilicus, so umbilical cord around the belly button. Abnormal skin or unsuspected focus of infection. Again, a lot of times if you're trying to take a culture from where the skin flowing up, and you see some bullae, you're not going to get anything back. You have to find the initial site and source of infection. Because what's actually causing the skin to peel off is not the Staph aureus bacterium itself, it's the exfoliative exotoxin. So if you go to the skin, you're going to find the exfoliative exotoxin, but that's a protein. It's not going to grow. If you're trying to look for growth of that bacteria, you're probably not going to get it. Again, sometimes if you really can't piece together what this is, and it's a very complex case, you might have to do a skin biopsy. We try not to do that because that's not pleasant. And they're already in severe pain. Treatment, IV means intravenous, so IV ampicillin, amoxicillin, vancomycin. I'll come back to what CA and MRSA means here in a little bit. So anytime you see CA, it means community acquired. So what does that mean? Community acquired, autosomal resistant Staphylococcus aureus. That means patients come into your practice and you see a lot of them coming in with MRSA. They haven't been originally admitted to the hospital. It's not a hospital acquired infection. They're just coming in randomly from all over the place and everybody has MRSA. That means you have a high prevalence of cases of MRSA in your community. So you have to treat people that have Staphylococcus infections differently than what you normally would. Since you treat a bunch of them like you just assume they already have MRSA because it's so high in the community. So that's one that comes into play. So you treat those people affected by some of those things. Another 42-year-old man presents with a non-painful enlarging lesion on his left hand, has sustained a minor injury a week ago, redness and swelling began 4 days ago. Lesion is drained and it has a thick yellow material in it, pus, and do a gram stain. Do a gram stain, gram positive, arranged, staphylo arrangement, shape is cocci, so staphylococci, probably Staph aureus. You typically see these types of infections if there's some kind of an injury, and then it progresses into cellulitis. 79% of cellulitis cases are going to be caused by Staph aureus. Group A streptococci, which is Strep pyogenes. Group B streptococci, which we haven't talked about yet, but we'll get there. Viridans streptococci, which we also haven't talked about, but we will get there. Or Enterococcus faecalis. Enterococcal species are included in Group D streptococci. Staphylococcal diseases tend to be indolent focal infections. So, we're talking about focal, medical terminology people. We talk about what indolent means. So indolent means it's not painful. So anything you see that. Examples of these different kinds of cellulitis. If it's around the eye, it's called periorbital cellulitis. An infection in the anterior portion of the eyelid, not involving the orbit or other ocular structure, it's more common in children. Usually diagnose it based on what it looks like, see what it looks like on the right, and you treat empirically. Another thing too is that we get these words as I go through the course. Empirical versus targeted therapy. What's the difference? What's empirical therapy? Yeah, use it broad spectrum, generalized, good. So somebody comes in with, we're going to talk about cellulitis, because they come in with this infection. You take a sample from that because you're going to send it to the micro lab. Well, micro lab is going to have to grow it up most likely, so it's probably going to take at least a day or two, maybe 3 to get the results back, depending on what's causing the infection. So you don't know what to give them initially because you're not entirely certain what the infection is caused by, so you don't know what the bacterial cause is. So you usually prescribe them something that's more broad spectrum to kind of knock out everything you think might be causing this type of infection. And then after 2 or 3 days, you're supposed to, especially if you're in a hospital setting, you're supposed to do something called an antibiotic timeout, which is exactly what it sounds like. Take off that empiric antibiotic, we look at the lab results, see what actually caused it, and then you go to something that's more targeted to knock that one thing out. That tends to not push drug resistance as much as just giving everybody broad spectrum antibiotics. Because broad spectrum antibiotics are going to positively select the bacteria that might have mutations and make them resistant to them. And then if somebody comes back in later on, you can't use that antibiotic anymore. Because some of those bacteria that might have a mutation allow them to become resistant to that antibiotic might be monoflora. So you have to be careful with broad spectrums. Same thing with the broad spectrums also gives up a lot of your normal flora to where you might, if you're you might get yeast infection, this is going to knock out the lactobacilli in your genitourinary tract, so you can see an outgrowth of yeast. If you're a human being at all, you might have Clostridium difficile in your gastrointestinal tract. If you knock down all of the bacteria in your gastrointestinal tract, you'll have to see different over to the Clostridium difficile infection. So broad spectrums are not good necessarily. If you don't use them with moderation.
Will you see this infection with diabetes?
You can. Yeah, oftentimes, and we haven't got there yet, but we will talk about those types of infections. Can't remember what day it is, but it's not. Hold on, I can't tell you what day it is. It's Wednesday, Monday. So it's about 2-3 weeks, we'll talk about that. What happens with those kind of patients is a lot of times they have diabetic neuropathy, so like they can feel it on the foot real well, and they have this really bad infection that progresses, and then it causes, unfortunately, potentially to lose their foot. Because it progressed so badly, because they lost sensation. We'll talk about that. These kind of periorbital cellulitis infections, they can result from infections such as cystitis. Try to say that once, if not once. That's inflammation of the lacrimal sac. So you could progress a cellulitis from this type of infection of that lacrimal sac. You don't really need to know as much about that, just more about what in general kind of cellulitis is. Cellulitis, again, most oftentimes going to be caused by Staph aureus. Risk factors tend to be previous trauma. It could result from some underlying skin lesion, but a lot of times it tends to come from some kind of trauma. Days after the trauma, they're going to have tetanus in that area. It's going to be red. It's going to hurt. They might have malaise, fever, chills develop. Or the cellulitis is raised but not well demarcated. Demarcated is another one we haven't really talked about yet. You talk about demarcation in medical terminology. So demarcated means you know that where it's red and where it's not red. Usually well demarcated. So oftentimes you have somebody comes in with skin soft tissue infection. You're trying to see how fast that's spreading. You take like a Sharpie, I'll take a marker, like say, like it's red, like right here. You go along that leading edge where it's well demarcated between red and where it's not red, and you take that marker and you put it right in front of that red spot, and then you come back 6 hours, 12 hours, whatever, and you look at it, you see if that red has moved past that marker spot, and you can start to gauge how fast it's moving. So that's what demarcation is. How where it's red versus where it's inflamed versus where it's not. Lab findings for cellulitis, oftentimes you're going to be non-specific. It might include things like leukocytosis. What's leukocytosis? Remember, I forget to tell you now. What's leukocytosis? What does leukocytosis mean? So we're going to talk about white blood cells. Yeah, you're going to see more white blood cells. Why do you think you see more white blood cells? You have an infection. Some of these infections, as we go through, are going to cause leukopenia. Leukopenia means the amount of white blood cells go down. So remember, some of these infections, while there might be white blood cells being made to fight them off, some of them make things like leukocytes, they can kill the white blood cells. So some of these infections, you'll see the white blood cell count actually go down, which probably seems a little counterintuitive, but that's why you see that. Elevated inflammatory markers like erythrocyte and sedimentation rate. We usually refer to that as ESR, as an acronym for it. So anybody in MD probably has not seen that. ESR, so erythrocyte sedimentation rate, is literally they put some of your blood in a tube and they see how fast the red blood cells settle out. This is why this is called one of the non-specific ones. If you have an inflammatory response, the red blood cells settle out faster than someone that's not having an inflammatory response. So that's ESR. That's a symptom, or that's a only non-specific kind of lab findings for cellulitis. Increasing erythrocyte sedimentation rate. The other one is elevated C-reactive protein. C-reactive protein is made by your liver in response to inflammation. So you can see more C-reactive protein in the blood in patients that are undergoing some kind of inflammatory response. So again, they're really non-specific kind of symptoms or laboratory findings because you see these for pretty much anything that causes inflammation. Elevated ESR and CRP. Treatment, you don't even know. However, I do want to make a little comment here about the way you treat some of these things. For cellulitis, Staph aureus may have an altered PBP2 protein. PBP means penicillin binding protein. cells actually more make glycan out of the cell wall. Those proteins actually bind penicillin. So penicillin was used in those experiments a lot to see the process of how glycan is made. So a lot of those proteins are therefore called PBP proteins, penicillin binding proteins. That's all that means. And literally, some bacteria can have a mutation in that penicillin binding protein too. There's an automated new cell. And that makes them not respond to the target that penicillin binding protein is involved in cell wall synthesis. All PBP2A means is penicillin binding protein 2 altered. So it has one mutation, makes a difference, so it's not responsive to penicillin. And has a low affinity for beta-lactams. Beta-lactams target cell wall synthesis. Examples of beta-lactams, penicillin, penicillin, things like that. You don't need to necessarily know anything about the treatments, but I do want to make sure that you do understand, since you've been through Gen Micro and you're in Path Micro now, that you understand giving somebody an antibiotic does not make them resistant to that antibiotic. Just the bacteria have mutations, and then they become resistant to it. That antibiotic doesn't make them resistant to the antibiotic. The only thing that antibiotic does is positively select for microorganisms that are resistant to that antibiotic. So it's not, that's not what you should do. Alright, so cellulose. This one's a little weird. Not necessarily super duper sure about what causes this one. This is called colloidal cyst. You see this about 26 out of 100,000 people. Average age is 19 in women, 21 in males. Males tend to be affected 2 to 4 times more often than females. You encounter it a lot of times in surgical practice, and you have this kind of situation. This can get really bad because if it gets bacteria, or maybe it already has bacteria, we don't know. It can cause a central nervous system infection because that is not very important for your spinal cord. Risk factors for it: obesity, local trauma or irritation, sedentary lifestyle, essentially a deep cleft in that area, increased hair density around that natal cleft, or family history of this. Diagnosis is based on how it presents, so you can kind of tell based on where it's located, what it looks like, that it's colloidal cyst. The problem with this is when you try to take a sample of these, you never get anything back. So we believe, and the reason I put it in this lecture, is we believe it's caused by probably Staph aureus or something like that. But when you try to culture from that area, from the actual lesion itself, you don't get anything back. However, based on where you see it, and that area is sweaty, and you see it in more obese people where you might have skin folds that could get sweatier, or you can have like the skin rubs together and cause some irritation. Kind of like we talked about, like I was talking about collaring your shirt around your neck, and it can cause irritation, at least tonsillitis, and then so that kind of fits for something like a Staph aureus. Sedentary lifestyle, you're essentially sitting on it all the time, it's sweaty, you get that kind of in that region. People that tend to be hairier there tend to have a high risk for this type of infection, which also points to maybe this starts as something like an early tonsillitis. Like all the kind of things kind of point to, it looks like some of the things we've already kind of talked about already today. But if you try to focus that, you're not going to get anything back. Like I said, it's kind of weird. It's probably a staph or a strep. But I hesitated on putting that slide in there for that reason. But yeah, probably a staph, but we don't know for sure. Antibiotics are limited for somebody that you've proven that cellulitis already. If they're symptomatic and this infection in quotation marks is very bad, you might have to drain that cyst to make sure it doesn't spread into deeper infection. Because again, that's close enough to the central nervous system that if it is caused by Staph aureus and that is some kind of progression of cellulitis, that is way too close to a lot of other regions to mess around with. Alright, so let's talk a little more just about staff orders. Gram positive oxide reduces clusters, you all know that. It makes catalase, which degrades neutrophil derived hydrogen peroxide. Remember, catalase breaks down hydrogen peroxide into water and oxygen. Oxygen makes levels in the catalase test. We will do that test here soon, very soon. I just saw my syllabus here somewhere. Coagulase is bumming me out here lately. Coagulase, we've talked about. Staph aureus essentially hijacks your fibrin and shields itself, coats itself in your fibrin. That is due to an enzyme called, or various factors, I should say as well, called coagulases made by Staph aureus. That is a really cool reaction to see in the laboratory setting. You don't know if we're going to get to see that in this semester. What you end up doing is in a test tube, I'll try on video this for you. In a test tube, you have fibrin from rabbit, usually it's from rabbit. You put the bacterial cells in it, like you inoculate the coagulase test. When you let it sit for a little bit, it starts to clump up that fibrin in the coagulase test. So you can visually see it for the tube. Sometimes it clogs up the fibrin so much that if you take the tube, you can actually turn it sideways and it's not a liquid anymore. Like it doesn't, the fluid doesn't turn, doesn't move. So it's a really cool test. The problem being, what I was trying to get to here, is we ordered these tests for this class last April, and they are still not here. And I don't think they're coming. And I don't know why. We just got an update that they won't come until December. Original ship date was supposed to be October. So I'm thinking they ain't coming. So I'm gonna try to let me see if I try to score coagulase test from somewhere. I don't know if I'm going to be able to do it. I'm thinking probably not. But at least I'll find a video or something to show you what it looks like, because I do want you, it's a really up to that. Staph aureus can make staphytoxin that activates superoxide function, so it can't get rid of superoxide free radical, which is something else can be made by neutrophils. Some more toxins that staph aureus can make. It can make an enterotoxin A, each food poisoning. If you have somebody that ingests it again, and you kind of start to figure this out as you see all these toxins that Staph aureus can make. Every system, organ system we talk about in here or in infectious diseases, use talk about Staph aureus because Staph aureus makes all kinds of toxins, can allow to cause pathogenesis pretty much everywhere. It can cause food poisoning because enterotoxin A. It can cause toxic shock syndrome because it makes toxic shock syndrome toxin and sometimes two. 1 and 2. That locks on that MHC class 2 receptor and T cell receptor together. So your white blood cells, your T cells, your phagocytic cells are just making cytokines like crazy. So you end up getting this inflammatory response that is out of control. It can make an exfoliative, this is an exfoliative exotoxin, which is what you saw with the skull skin syndrome. It can make another exfoliative toxin A, which is what you see for cases of bullous impetigo. Those Staph aureus isolates make that toxin. It can make a Panton-Valentine leukocyte, which if you ever sit for any kind of a medical board, they'd love to ask about Panton-Valentine leukocytes for some reason. You see this produce what community acquired leukocytes, that's pretty much all that make it, and it wipes out white blood cells. Those white blood cells damages the cell membranes. You see it associated with skin soft tissue infection. There you can see it a lot more often in your patients. Something that I should point out here to you, just to make sure that we're on the same page with stuff. Can anybody tell me what the difference? What's a bacterial strain? So if I told you like we're going to look at this strain of Staphylococcus aureus today, what am I talking about? Because I realize oftentimes that we probably don't talk about this enough either. What's a strain, like a bacterial strain? Yeah.
That's like a species?
Yeah, it's like a subtype of a species. So it means they're not, so strains are not genetically different enough to be different species. but they're different enough to be different strains. So they're not different enough where you can make them different species, but they do have subtle differences. So like if you look at like a lot of the E. coli work, they're like E. coli, K12, they're like laboratory strains, they have the core genome, which if I remember correctly for E. coli, digging real deep here, the memory, I think is around like 4.6 like databases. But then if you have like an E. coli 5787, instead of having like 4.6 megabases in its genome, it's got like 5.7. It's got like another million base pairs. Those other million base pairs have a lot of variance factor genes. It's not gonna cause you to be ill from E. coli 5787. E. coli K12. Don't do this obviously, but I mean, like K12, you can drink that stuff, that mentioned past through the last main line. It doesn't have any variance factors. I mean, it just, it's not going to be able to establish an infection because there's no variance factors. But K12 is a strain of E. coli, but 15787 is also a strain of E. coli. They are different, but not different enough for them to be different species. So we talk about this, some of these strains that were isolated from, say, clinical environments, or sometimes you'll hear me refer to them as isolates as well. I usually use strain and isolate interchangeably, for better or worse. Some strains are going to make some of these things, no Staph aureus. Some strains are going to make, that Staph aureus are going to make all these things. Some strains of Staph aureus could potentially make none of these things. Just depends on what strain. The Staph aureus we use today is a laboratory strain. It's been passed through this laboratory for so many years. It's going to be one of the ones that probably doesn't make a lot of anything. It's going to be pretty wimpy. In fact, the Staph aureus you have on your skin is probably going to be a lot nastier than the stuff we use in here. Just based on where you find it. Some more variance factors. Again, this is why we talk about Staph aureus so much. It's got a pretty good odor. It makes capsule about 90% of isolates. And it can use avoid things like doses. It can make adhesins that adhere to host cells. It can make protein A, which is going to attach to that constant region of antibodies to block interaction with constant region receptor on white blood cells. So it blocks opsonization. It is a gram-positive, so they're all going to make tecoic acid. That tecoic acid can be used for adherence to organisms. It can also induce production of cytokines. They all make peptidoglycan because they're gram bacteria. But that peptidoglycan itself can actually trigger a sepsis cascade that looks a lot like endotoxin and septic shock. So again, Staph aureus has a lot of weapons to cause some pretty nasty infections. We'll talk about a lot of different places. We'll talk about the skin infections like we do here today, folliculitis, abscess formation, and impetigo. It can cause a specific kind of pneumonia secondary to influenza infection. Specifically, it's a necrotizing cavitary pneumonia, which means it causes the formation of cavities in your lungs. And a lot of times, because the Staph aureus is a pyogenic disease, means it can make pus. You see these cavities on like chest X-ray, and then you see at the bottom of the cavity, you see like this little kind of line, because the cavities are filling up with pus that's being made with the Staph aureus. It can cause really nasty pneumonia that way. We'll talk about that in probably a month or so. It can cause septicemia. It can go into the bloodstream. It can cause endocarditis. If it causes endocarditis, that's usually a focal infection. What's a focal infection? What a focal infection is? It goes to the tissues, good. So a lot of times it starts out somewhere around like the nasopharynx, somewhere in the oral cavity, spreads to the tissue. It can cause some real nasty things. Food poisoning. There's a case I wrote up some time back that actually one of my colleagues came in and talked to seminar on medicine about, where who's in the seminar on medicine? Essentially, there's a patient that came in. There was an individual that and her partner were doing IV drugs, and her partner thought that she had OD'd. They were on this goat farm, and he thought she just needed some kind of, she was dehydrated, so he went and got a used IV bag with normal saline in it that had been used on goats, that was also expired and a bunch of Staph aureus that were inside that IV bag. So he essentially infused her with the big culture of Staph aureus. Staph aureus can cause infection anywhere. So, I mean, that individual ends up with Staph aureus in the brain, Staph aureus in the lungs, Staph aureus in the gastrointestinal tract, Staph aureus in the everywhere. So it has the capacity to cause infections very systemically. Not good. Okay, so remember, even though a lot of these infections we talked about are caused by Staph aureus, a lot of them can be caused by group-based strep as well, like streptomyces. Graham saying what that looks like, strep two, coccygeal arrangement based on shape and morphology, divided into groups based on Mansfield antigens. Most of them are, there are some that don't make those. Catalase negative. So one of the main ways, one of the quickest ways you can tell them between Staphylococcus aureus and Streptococcus species is by doing a catalase test. They spear on the slide, they drop some hydrogen peroxide on it, and see if there's some bubbles. It is the easiest way to do this. Are there other ways? Yeah, they're totally different. That is the easiest. Basic tracing sensitivity, we'll do a lab, we'll talk a little bit about that more later, but it is sensitive to basic tracing. Sensitive base tracing, and again, the predominant number of group-based strep's and strep pathogens is the only one that you need to worry about. Group-based strep can cause impetigo and cellulitis. Treatments you don't need to know. However, for like impetigo causing group-based strep, you should treat it with Puricin, which is pretty much what you use to typically treat impetigo anyways. If it's not, so this is something else, you don't need to know what the drugs are, but I want you to understand what the difference in prescribing is. If it's not virulent, you use some different antibiotics than if it is virulent. Because remember, if it's virulent, that means it makes pus. If it makes pus, it's probably staph. If it doesn't make pus, it's probably strep. Strep tends not to make pus. Staph tends to make pus. So you treat those different types of bacteria differently. What alpha, beta, and glioma molecules looks like on the plate, we talked about that, you can see it there again. Different virulence factors, group-based strep makes, M protein help present phagocytosis. A lot of that is because of molecular mimicry. That M protein has similarities to proteins in your body, therefore your immune system tends to not to attack it because it doesn't recognize it as non-self. So that's your M protein. It makes a hyaluronic acid capsule, which inhibits phagocytosis by a couple mechanisms. One of them being the capsule itself just inhibits phagocytosis because it makes the cells of the bacterial cell bigger. The other one is you make hyaluronic acid too. So you can use that hyaluronic acid capsule as a kind of molecular mimicry too. So your immune system doesn't necessarily recognize the group-based strep as foreign because it sees that hyaluronic acid. They can use that hyaluronic acid to shield a bunch of things underneath that capsule. So it doesn't recognize it as foreign. It makes a hyaluronidase. They use to break down hyaluronic acid in your tissue, because again, remember, it uses that hyaluronic acid to hide the immune response. You can also make a hyaluronic acid to break down the hyaluronic acid you make. Let me ask you that question. Do you think that when bacterial cells are, do you think when group-based strep cells, strep pyogenes cells are making new cells when they're verifying your vision, do you think they're making hyaluronidase or not? So it makes a hyaluronic acid capsule, right? So when it's making more hyaluronic acid capsule, it's not going to be making that enzyme. It's going to break down the capsule. So this is where some of the stuff gets a little bit more confusing, because it has the ability to make things essentially counteract one another, right? So its expression of those genes for those different virulence factors is going to be controlled. It's only going to make the hyaluronidase at certain points of infection and certain points of growth curve. So if you have one cell that's trying to make a new cell that's going to make more hyaluronic acid capsule, it's going to shut down the production of all that hyaluronidase. Then once the new cell is made and has that capsule, then it can start making hyaluronidase. But all that gene regulation is interconnected with one another and controlled. We're essentially looking for a cell, or at least a scaffold. Streptolysin, it uses for lysis of red blood cells, so they have lungs. Exotoxin A, it can use to trigger shock by making interferon gamma to resist factor alpha. So just know exotoxin A is used for shock. What we were just talking about again, streptokinase and streptokinase. Streptokinase is going to digest fiber, preventing blood clotting, allowing the bacteria to spread. Streptokinase is going to be made when the strep pyogenes is in a bunch of pus. It's going to help liver fly that pus so it can actually escape that site of infection. But again, fruit-based strep doesn't make a ton of pus anyways. What is made, it makes this break down. So that's one of the other reasons you don't see a lot of pus form, because it literally makes it very much factor to break down pus. So a bunch of different factors. Some of them directly associated with different kinds of disease processes. They call it mixing erythrogenic toxin. This is associated with sclerotic fever, which we'll talk about here when we talk about respiratory tract infections. Makes a pyrogenic exotoxin A that's involved in causing fever and involved in streptococcal toxic shock syndrome. That exotoxin A, anytime you see pyro, so something else to keep in mind, PYRO means fire, so pyrogenic means it's causing fever. Pyogenic, PYO, means it's producing pus. So one letter difference can really goof you up there. So pyo means making pus, pyro means making fever. Some of them that cause necrotizing fasciitis makes an exotoxin B. That exotoxin B is associated with causing the symptoms of necrotizing fasciitis, which we'll talk about on Monday. And again, some of these different risk factors under the table you see associated with different types of infections. One of them being ecthyma. Ecthyma tends to be caused by fruit-based strep. It's caused usually, doesn't proceed from any other like kind of infection or your shirt rubbing on your neck or anything like that. It usually just kind of seems like it kind of comes out of nowhere. It's usually secondary to a lesion, which is why it usually seems like it comes out of nowhere. Somebody comes in, they've been bitten by some kind of an insect, and then they start to see lesions that look like this. It just kind of happens. It's an ulcerative, technically it's an ulcerative form of impetigo. It starts out kind of similar to impetigo, but you start to get these lesions that look like somebody took a biopsy, punched their skin. We know what a biopsy punch actually looks like. I swear I'm going to break this in on that brain. Since you have this thing that looks like a metal cylinder, you can push that down the skin to remove like that cylinder sample, that biopsy. So it looks like somebody poked a hole out of the skin, out of the tissue. So that's what it means by a punched out lesion. A lot of times the lesions tend to have like a greenish or yellow kind of rust on top of them. It does penetrate down into the epidermis, so it's a lot more penetrating of an infection than what just impetigo is. It can start to begin to have purplish margins. You usually see this in children and older adults. A lot of times you see it on the lower extremities, on the legs. The treatment is the same for impetigo, but it is more penetrating than just a normal kind of run-of-the-mill benign impetigo type of infection. Something I would like to note as we go throughout this, as you do progress out of this university, go to professional school, wherever it is you may go, something you will realize, I think, very quickly in your medical textbooks is they are very bad, especially for skin and soft tissue infections, at using images of people that have melanin. They tend to usually be for Caucasian people, which makes it sometimes hard to teach what it looks like in like African Americans, Hispanics. That is just how it has been, unfortunately. Yeah. So that's why if you see a lot of these pictures up here that tend to have people with lighter colored skin, that is an artifact in the medical literature, unfortunately. And something that we need to definitely improve on, because it makes it very hard to teach sometimes. When the only thing you have is a bunch of pictures of white people. That is something. Okay. Another one, erysipelas. So erysipelas, this is another one that's kind of weird. Like the whole presentation of this has changed over the past 20 years or so. You used to really see infections with this on the face. As you can see kind of with this individual up here on the screen, you can see it associated on the face. Now you tend to see it with extremities. Why that changes over time, we do not know, but it is different now. It used to be used in the face, topic based strep, common infants, young children, older adults, that's still the same. So people with kind of more suppressed immune response because it's not well developed, or it's kind of like weaker over age over time. 78% of lesions involve the lower extremities now. 5 to 20% of the lesions occur on the face. You used to be able to almost switch those numbers. It used to be 70-80% occur on the face and 20% on the legs. Now it's 80% on the legs and arms, 20% on the face. So, yeah. Very weird. Streptococcal bacteremia occurs in about 5% of these patients, so you have to be cautious of this one, make sure they don't have bacteremia. Diagnosis of it is based on appearance of the lesion. It's a painful lesion, bright red, edematous and indurated. What does edematous mean? You know that one? Oh, it means fluid, bring fluid to the area. So edema, bring fluid to the area essentially. Edematous means it's usually edema in that region. Indurated is where it's raised. It's sharply demarcated, which is why I turn off the lights, especially today. This is really hard to see. If you look really hard here, you can see like where, so I use the pen here to outline where this is red. It's because they're trying to watch how fast this is spreading, or if it is spreading. This is an image I pulled from Up to Date, which we use in clinical practice to look up things. This is like, how should I treat this today? Or what's the common presentation for this? So it's kind of like a desk reference, but it's all digital. It's super expensive. Fever, if it's on the face, it usually involves the cheeks and the bridge of the nose, just like the image that showed you, which I also pulled out Up to Date. Yeah, that's also on Up to Date. Leukocytosis is common, so again, white blood cells are going to go up because you have infection. Mild early cases you treat with penicillin. Keto means oral. Procaine, penicillin. IM means intramuscular. Or very bad cases with a different form of penicillin, penicillin G, which is also orally. Where this gets confused for things sometimes is sometimes you can confuse this for herpes zoster early on. So what's herpes zoster? You know what herpes zoster is? Right, good. Herpes zoster. Herpes zoster is a herpes virus. So when people got chickenpox, we used to call it herpes zoster. We don't call it herpes zoster anymore because, if you have a young child come in and you tell their parents they have herpes zoster, people think herpes, their mind goes to a different place than chickenpox. So they eventually just caved and just changed it to varicella zoster. It's a herpes virus. In every sense of the word, it is a herpes virus. What happens with the chickenpox? So chickenpox, usually you would take it in the respiratory route, and then you get the presentation of chickenpox in children. And then what that chickenpox virus does, that herpes zoster virus, it goes and it lays dormant in your dorsal root ganglia at the base of your kind of like down here. And then later on, you become immunocompromised, whatever, you have a hampered or weakened immune response. That herpes zoster virus comes out of the dorsal root ganglia and causes shingles. Shingles is a lot more painful than chickenpox for a couple reasons. One of them by being a lot more BS than the other one. The way we used to teach this is just like, well, essentially adults have more of a pain repertoire. So children have been exposed to much pain, so they don't really know what pain is. That would be the one that I refer to as BS. The real reason is chickenpox doesn't emerge from the root of your nerves. Shingles does. So it's going to hurt
because it's right at your nerve endings.
The shingles vaccine they give you is the exact, if you're 55 or older, the shingles vaccine is exactly the same as the chickenpox vaccine, except it's like I think it's like a 5x dose. It's just a way higher dose. It's just to make sure it's like to re-stimulate your immune system.
Oh yeah, I remember what that was.
So if you do start to have those viral particles emerge from your posterior ganglia, your immune system points them out. That's what the shingles shot is for. If you were exposed as an adult, this is something else that you might not have had before. If you were exposed to varicella zoster virus, herpes zoster virus as an adult, when you get chicken and you've never been exposed to it before, you get chickenpox or shingles. You get chickenpox. Sometimes people get that confused, which is like, okay, if I exposed to it the first time as an adult, I'm gonna get shingles. Like, no. You always get chickenpox first, regardless of what the age is. Chickenpox will eventually lead to you getting shingles potentially. Like I had chickenpox as a kid. Like I didn't have like this chickenpox vaccine like all the fancy people. Yeah, so I might get shingles later. So I got that to look forward to. What can happen sometimes is when that herpes zoster emerges to shingles, depending on where it emerges from, if it comes out of the fifth cranial nerve, it can look like this. So sometimes you get somebody misdiagnosed with shingles that actually really doesn't have shingles, they end up having erysipelas. And since erysipelas, even though it generally doesn't cause sepsis, can cause sepsis, that's a problem.